I'm Dr. Moy. I'm one of the EM regists. I'm currently rotating at RMMCH, doing my pediatrics rotation. So I chose a topic, congenital heart disease, which is actually a very big topic. But I'm not going to basically go into depth because of the size and the number of obviously congenital conditions there are. Some I'm going to go a bit deeper, others I'm just going to basically be superficial. But at the end of the presentation, I put my references, one of the books that I used to get some of my materials that I used for the presentation. Okay. So in terms of content, we're just going to basically be going through some of the definitions, some fetal circulation, also some of the different and classification of congenital heart disease, and some assessment and management of these congenital disease. What are basically congenital heart disease? These are cardiac anomalies arising as a result of a defect in the structure or the function of the heart and great vessels, which present usually at birth. And then these lesions either obstruct blood flow in the vessels or vessels near it, or alter the pathway of the blood circulating through the heart. So in terms of the causes, we have different causes ranging from environmental conditions, also some genetic factors. Some of the environmental conditions that patient can be exposed to causing these are viral infections, usually obviously when the mom is infected. This can basically happen in utero. And then in terms of medication, if the mom is on any mood stabilizers like lithium, this can predispose the kid to have these congenital condition. And then obviously drugs and such as alcohol and cocaine can also cause these, and maternal diabetes and also patients with folic and vitamin B deficiencies are also at a high risk of developing, having kids that develop this condition because of these. And then in terms of genetic factors, some of them obviously it's genetic, so hereditary conditions, and obviously some mutation can also predispose babies to have these. And others obviously are also linked to other birth defects such as Down syndrome and also Turner syndrome. And then in terms of circulation, so I'm just going to basically briefly go through the fetal circulation while they're in utero. We know that there's one vein and two arteries. And then in terms of the circulation, blood basically circulates from the placenta, and then it goes into the IVC, and then right into the right atrium, and then it can either go through to the right ventricle or the left atrium via the foramen ovale. And when it goes through the left atrium, it then goes to the left ventricle, and then from the left ventricle, it then obviously goes to the aorta, which is basically going to supply the head and neck. And then in terms of returning to the heart, is going to return through the superior vena cava, and then again into the right atrium. And then if ever blood obviously goes into the right ventricle, it then obviously goes through the pulmonary arteries. And then from the pulmonary arteries, it goes through to the aorta via the PDA, the patent ductus arteriosus, which basically supplies the lower extremities of the baby's body. And then from the lower extremities, obviously, then the blood circulates back to the placenta. And then, so in terms of groupings, so there are 4 pathophysiological groupings that we use. So the acyanotic left to right shunt. So these are obviously ventricular septal defects, and also our atrial septal defects, and also our patent ductus arteriosus, and also atrioventricular septal defects. And then the other group of acyanotic obstruction lesions, these can be your pulmonary stenosis, aortic stenosis, and also coarctation of the aorta. And then in terms of our cyanotic congenital heart disease, these can range from tetralogy of Fallot, also pulmonary atresia, truncus arteriosus, total anomalous pulmonary venous drainage, also tricuspid atresia, transposition of great vessels, and also the Eisenmenger syndrome. And then the 4th group they usually talk of is the regurgitant lesions. So these are your aortic incompetence and mitral incompetence. So these can be classified basically under acyanotic lesions also. And then in terms of division from the acyanotic. So you get those that increase the pulmonary blood flow. You also get those that cause obstruction to blood flow, basically from the ventricles. And then the ones that cause increased pulmonary blood flow are your ASDs, your VSD, and your PDAs, and also your AVSDs, malformations. And those that cause basically obstruction to blood flow from the ventricles, these are our coarctation of the aorta, our aortic stenosis, and also pulmonary stenosis. And under the cyanotic grouping, so we have lesions that decrease pulmonary blood flow, and those that actually mix blood flow. And then from the decreased pulmonary blood flows, you get tetragedy of Fallot and also tricuspid atresia. And then those that cause mixing of blood, it's usually your transposition of great vessels, your total anomalous pulmonary venous return or drainage, and also your truncus arteriosus, and also your hypoplastic left heart syndromes. Just to remind you guys, Tammy just asked me to ask you guys to put in your details in the, I think the chat box for CPD points purposes. So you guys can do that while I'm talking or even towards the end of the presentation. And then starting off with our acyanotic heart disease, the first one being the ASD. So there are different types of ASD. We have the ostium secundum, which is basically a defect in the middle of the septum. And that's the most common one that we see in our PED patients. And we also have ostium primum, which is basically at the lower section of the septum. And then it's also like a form of an AVSD. And then we also get the sinus venosum, which is at the side of entry of the supravenar cava. Basically, this is the least common one. And in general, most defects smaller than 5 millimeters recognized during infancy are likely to spontaneously close, but those with a diameter larger, usually than 8 millimeters, rarely close spontaneously. And if patients either have surgery or not, adults may have atrial arrhythmias because of these lesions. And usually spontaneous closure is not likely to occur after 4 years of age. And in terms of clinical presentations, they would usually have like shortness of breath, some fatigue, and also get tired while feeding, which would result in stunting of these babies. And then in terms of diagnosis and management, so usually the right ventricle and the right atrium have increased compliance, hence they have increased radiological markings. The dilated right ventricle cavity usually prolongs the time required for depolarization of the right ventricle. And then this produces either like a complete or incomplete right bundle bunch block when we do ECGs. And then right bundle bunch block patterns in children with ASDs is not the result of an actual block in the right bundle. And children with ASD, they really experience congestive heart disease, even in the presence of a large left to right shunt. The pulmonary arteries can actually handle the increased amount of blood flow for a long time without developing any pulmonary hypertension or congestive heart disease because there's no direct transmission of the systemic pressures actually to the pulmonary arteries. However, congestive heart failure and pulmonary hypertension eventually develop in the third or fourth decade of life if the shunts are large and are not corrected. And then usually echoes we do obviously as a diagnostic features. Those that have rotated in cardiology would have noticed that the ideal echo is the transesophageal echoes that they do for these lesions, but you can still see it with the transthoracic. And then in terms of management, usually obviously if ever they end up with congestive heart failures, your diuretics can help, especially with large defects. And like I said, in terms of surgical intervention, closure is usually done between the ages of 4 to 6 years of age. And then in terms of VSDs, this is obviously a defect within the septum between the ventricles. There's also 3 types that we find, which is the supracrystal VSD, which is beneath the aortic valve, and also the membranous VSD, which is the most common one that we see in our pediatric population. And then we also have the muscular VSD, which occurs mid to apical septum. And then usually with the small VSD, patients are usually asymptomatic with the normal growth and development. But once they start having moderate to large VSD, we usually see delayed growth and development, and also a decreased level of activity. And then they usually end up with repeated pulmonary infections, and also congestive heart failures are relatively common during infancy. And then in terms of spontaneous closure of membranous and the muscular VSD, it can usually occur. It occurs more frequently if ever the defects obviously are smaller and during the first 6 months of life. And then VSDs do not actually become bigger with age, rather they decrease actually in size. And also same thing in terms of presentation, they would have shortness of breath and also poor feeding, and then this sort of actually affect their growth, so they would have stunted growth. And then in terms of diagnosis and management, in VSD, it is the left ventricle that does the more work and not the right ventricle. So obviously this results in the left ventricle enlargement. So the right ventricle does not enlarge. And because of the shunt of the VSD occurs mainly during systole, when the right ventricle contracts, the shunted blood goes directly to the pulmonary artery rather than remaining in the right ventricle cavity. So therefore, there's no significant volume overload on the right ventricles, and the right ventricles remains relatively normal in size in a VSD with a moderate shunt. And then with the large VSD, the overall size is larger than seen with the moderate VSD, because there's a greater shunt because of the direct transmission of the left ventricular pressures through the large defect, which goes to the right ventricle. And then obviously that's where the only time you can get right ventricular enlargement and hypertrophy. So, and if ever obviously there's bilateral hypertrophy, so on your x-rays, you may see that biventricular enlargement also with the left atrial enlargement. And in terms of management, so these patients, obviously they may also have some failure, so digoxin and diuretics are advised, and then because of their growth being stunted from poor feeding, so dietitians are also involved, and they also basically advised to give high calorie nutritions. And in terms of surgical indications, obviously if ever the VSD is large, and then patients obviously having congestive heart failure resulting also in stunting, that's where surgical intervention is advised. And the VSD should be operated within the first 6 months of life. And then the patent ductus, it's a vascular tube that's basically connected to the pulmonary arteries and the aorta. And it most closes on the second or the third day of life. But PDAs are usually a common problem in premature infants. And a large large shunt PDA may cause some lower respiratory tract infections, can also cause some atelectasis and also some congestive heart failure. And we also see it in trisomy 21 and congenital rubella syndromes, and also presents similar to the other defects. So with poor feeding and failure to thrive, shortness of breath, and also with this recurrent chest infection I already mentioned. In terms of diagnosis and management, so the hemodynamics actually of PDAs are similar to those of VSD. The chambers and vessels that enlarge are the same as those in VSD, except for enlarged aorta to the level of the PDA, which basically handles an increased amount of blood flow. Therefore, PDA's chest X-ray films show enlargement of the left atrium and also the left ventricle. and a large ascending aorta and pulmonary arteries. And also you can see some pulmonary vascular markings on your chest X-ray. And then in terms of management, so currently transcatheter closure is a standard care beyond the neonatal period. And closure of PDA is definitely indicated in patients with hemodynamic significance, causing congestive heart failure if patients are having failure to thrive. So these patients are the ones that are used. So as you can see on the picture that I posted there, so we can use the catheter, which is passed through the PDA, and then a coil can be inserted, which remains there to actually close the PDA itself. And then other devices can also be used to close this PDA. And then the other thing that they can do, they can basically ligate the PDA. That's another surgical intervention that is usually done for these patients. And in terms of coarctation of the heart, so the usual location of coarctation is just distal to the left subclavian artery. Less often is proximal to the origin of the left subclavian artery. These patients usually have poor feeding dyspnea also, and they can actually have circulatory shock, which may develop in the first 6 weeks of life. Most children can be asymptomatic, but they do obviously complain of some weakness and pains in their legs when they do exercises. And then in terms of arterial pulses in the legs, they are either absent or weak, or they may be delayed compared to the arms. And then when you check blood pressure, there's usually a difference between the arms and the legs. And then when you do ECGs, usually see like a leftward QRS excess and also the left ventricular hypertrophy, which we commonly find on our ECGs. And our heart size may be normal or slightly enlarged. And then obviously with the dilatation of the ascending aorta, it's usually seen. And then in terms of diagnosis and management, like we already mentioned, a normal or right QRS excess and the right ventricular hypertrophy can be seen in infants with coarctation. And they usually have this marked sometimes cardiomegaly and also with pulmonary edema with venous congestion. And so you can also do like a 2-dimensional echo and flow Doppler studies to show the site and the extent of the coarctation. And then in terms of management, so in symptomatic neonates, they do speak of prostaglandins E1 infusion, which should ideally be started to promote ductal patency, which helps to establish flow to the descending aorta and also to the kidneys. And then you can also assist with some intensive anticongestive drugs, diuretics, and also some oxygen to start. And then when the patient is stable, either a surgical or balloon procedure should be performed to sort of improve blood flow. So there's different procedures that they usually perform. As you can see in the diagram, there's a patch angioplasty that they can do. They can actually resect the actual coarcted area and then just re-anastomose the vessel. Or they can even do a intraposition graft or even a subclavian flap. And then in terms of pulmonary valve stenosis, obviously there's some resistant blood flow causing some right ventricular hypertrophy. So you get different types. So the stenosis can either be valvular, which is basically the first image that you see at the second image, which is A, or it could be subvalvular, also known as infundibular, or it could be supravalvular, or within the right ventricular cavity. And in patients with moderate stenosis, exertional dyspnea and easy fatigue may be the signs that patients actually present with. And then with severe stenosis, exertional chest pain or syncope may be present, or even worse, they may have a sudden death when they have strenuous exercise. And newborns with critical pulmonary stenosis may present with poor feeding, tachycardia, and also cyanosis. And then in terms of in management, so ideally they also need some surgical intervention where they do pulmonary valvulotomy. And then with non-surgical intervention, they can do balloon angioplasty, which is sort of like a balloon that sort of dilates the valve itself so blood can flow. And aortic stenosis. So these also, we get different types. So in units with critical or severe stenosis of the aortic valve, they may develop signs of hyperperfusion or respiratory distress, which is caused usually by the pulmonary edema within days to weeks actually after birth. And most children with mild to moderate aortic stenosis can be asymptomatic. Occasionally exercise intolerant may be present with all these children. And then exertional chest pain and fatigability and syncope may occur in children with severe degree of obstruction. And then when you investigate them, usually on ECG, if ever it's a mild case, it may be normal, but left ventricular hypertrophy with or without strain pattern may be present in severe cases. And newborns with critical aortic stenosis may show some generalized cardiomegaly with pulmonary venous congestion on your chest x-ray. And then also in terms of management, so they also basically need balloon valvuloplasty or aortic valvulotomy to manage these patients in severe cases. And now moving to cyanotic heart disease, starting with the big one, which is tetralogy of Fallot. Usually there's four major defects that they usually speak of. The first one being the pulmonary stenosis, also with right ventricular hypertrophy, also an overriding aorta and ventricular septal defect. But from a physiological point of view, TOF requires only two abnormalities actually. So just a VSD large enough to equalize systolic pressures in both ventricles, and a stenosis of the right ventricular outflow tract in the form of infundibular stenosis, valvular stenosis, or both. So right ventricular hypertrophy is usually secondary to the pulmonary stenosis, and the degree of overriding of the aorta varies widely, and it's not always present. So the severity of the right ventricular outflow tract obstruction determines the direction and the magnitude of the shunt through the VSD. Actually, with mild stenosis, the shunt is actually from left to right instead of what we know as right to left, making it a cyanotic. So if ever it's mild, it can be from left to right, and the clinical picture resembles that of a normal VSD. And these are called acyanotic or pink TOFs. And then obviously with more severe, the shunt is from right to left, resulting in a cyanotic tetralogy of Fallot. And then in terms of clinical presentation, obviously they have your breathing difficulty and cyanosis, and then they usually have TET spells, which are hypoxic spells. A sudden increase in the right to left shunt appears to be the prime event of these hypoxic spells. So usually an increase in the pulmonary resistance or a decrease in systemic venous resistance will increase the degree of the right to left shunt, producing a more severe desaturation. So a decrease in systemic venous resistance increases right to left shunt by reducing the left ventricular and diastolic pressures, thereby increasing the pressure gradient between the right and the left ventricles. And then in addition to a decreased systemic venous resistance, other causes such as excessive tachycardia or hypovolemia can cause an increased right to left shunt through the VSD. And then in terms of management, usually these kids, usually when they're crying, obviously these exacerbates these hypoxic spells. So they speak of trying to calm them down. And also just if they're very small enough, you can put them on the mom's lap and they can do a knee to chest position. And this obviously helps with the venous return and to calm the patient. Can also give IV fluids. Also speak of slowing the heart rate if they are tachycardic with beta blockers. And then these interventions obviously increase the systemic venous return resistance or decreases the pulmonary vascular resistance. So all of these can be helpful in terminating this hypoxic spells. We can also give the patient morphine sulfate, which can suppress the respiratory center, because half the time, if ever they very have an increased respiratory rate, it can worsen this condition. So the morphine sulfate sort of helps to abolish this hypopnea. And then in terms of vasoconstriction, you can use drugs such as phenol to raise the systemic venous resistance. And this will also help to improve arterial oxygenation saturation. And other drugs that are usually used, these are your ketamines, which is a good drug because it simultaneously increases your systemic venous resistance, and it also helps to sort of sedate the patient because you want them calm. Just be able to help terminate these spells. And then in terms of other interventions, you can get your balloon dilatation of the right ventricular outflow tract and also the pulmonary valve. Although it's not widely practiced, but has been attempted to delay repair for several months. And then surgical interventions are usually indicated or performed for shunt procedures to increase pulmonary blood flow. And usually they are done to correct the VSD and also the pulmonary stenosis. And then your other cyanotics, these are your transposition of your great vessels. In this condition, the aorta arises from the right ventricle, and also the pulmonary arteries arise from the left ventricles. So in this defect is usually incompatible with life, unless obviously there's a communication between the two circuits to provide necessary oxygenation to the body. So this communication can occur at either the atrial or the ventricle, so they can have ASD or VSDs, or even PDA may sort of exist just to help with oxygenation. And then in severe hypoxia and acidosis and volume overload to the left of the heart, this can cause congestive heart failure during the first week of life. And these patients usually have also shortness of breath and poor feeding with the history that we take from our patients. And then in terms of diagnosis, chest X-ray show cardiomegaly and also some increased pulmonary vascularity. And then ECGs can show right ventricular hypertrophy. But the right ventricular hypertrophy may be difficult to diagnose in the first days of life because of the normal dominance of the right ventricle at this age. And then in terms of management, prostaglandins are also used to improve arterial oxygenation by reopening the PDA. And just before surgery, cardiac catheterization and a balloon atrial septotomy are often carried out to have some flexibility in planning the surgery itself. There's usually no palliative procedure performed unless, obviously, arterial switch operation cannot be performed early in life. So historically, the definitive surgeries performed for transposition of great vessels were procedures that switch the right and the left-sided blood at 3 levels. So these can be done at the atrial level, or the ventricle level, and the great artery level. And the next one is tricuspid atresia. So in tricuspid atresia, the tricuspid valve and a portion of the RV sometimes may not be existent, so it may be hyperplagic. So there's usually a flow from the right atrium through the foramen ovale to the left atrium, and then the left ventricle, and then to the aorta. And then sometimes there can be a VSD or PDA for the pulmonary arteries to receive blood, obviously for survival. In some clinical signs, they also have cyanosis, some tachycardia, and also poor feeding. And then in terms of diagnosis and management, so the right pressures on the right atrium are usually elevated, and this causes enlargement of the right atrium on X-rays that we can see. And they also have a right atrial hypertrophy that we see on ECGs. And then in terms of management, so again, prostaglandins should be started in neonates with the very severe cyanosis, just to maintain the patency of the duct before planning cardiac catheterization. And usually the surgery that's usually done, they call it the Fontaine surgery, because of the atresia of the tricuspid. Obviously, blood is not really flowing from this image, is not showing it very nicely, the atresia. So blood is diverted from the IVC, and then it's connected directly to the pulmonary arteries, since blood cannot flow from the right atrium into the ventricles and into the pulmonary arteries. So with the Fontaine, what they do is that they just take the IVC, and then they obviously connect it to the pulmonary arteries directly, and then they just have a small fenestration, which helps obviously with extra blood flow until the lung adjusts to the pressures coming from the IVC, and also from the superior vena cava. And with the pulmonary atresia, so direct communication between the right ventricle cavity and the pulmonary arteries usually doesn't exist. So the PDA is the major source of blood flow to the lungs. So the left atrium and left ventricle relatively are large because they received both systolic and pulmonary venous return. The right atrium dilates and hypertrophies to empty systemic venous return into the left atrium through the ovale, and then the right atrium enlarges and hypertrophies just to maintain the right to left atrial shunt. And the systemic and pulmonary venous return mix in the left atrium, and they go to the left ventricle to supply the body and the lungs themselves. And there's a history of a severe cyanosis usually from birth. And you usually need this intra-atrial communication, or PDA, for survival. And then in terms of diagnosis, when you do your X-rays, you do see some right atrial enlargement on X-rays, and then on the ECG, you get your right atrial hypertrophy signs on the ECG. Some management to your tricuspid atresia. So where obviously you need this prostaglandins for patency. And then the surgical intervention, it's similar, which is the Fontaine, which helps obviously redirect the blood. And then we also get your total anomalous pulmonary venous return. So the pulmonary veins actually drain up normally into the right atrium. So either directly or indirectly through some venous tributaries. And then ASD is usually present to send blood from the right atrium to the left atrium. So we usually get like 4 types. The common one, which is the supracardiac, which drains blood into your right superior vena cava. And then you get your cardiac type, which basically drains blood into your pulmonary venous sinus, into your coronary sinuses. And then you get your infracardiac, where it drains into your portal veins, or your ductus venosus, or hepatic vein, or even your IVC. And you get the mixed type, this type, which is a combination of other types. It usually accounts for about 10%. And then when you do chest x-rays, you would usually see enlargement of the right atrium and also the right ventricle, with prominent pulmonary artery segment, with some increased vascular markings. And then the ECG may show right ventricular hypertrophy or even a right bundle branch block. And infants with severe pulmonary edema, ideally they advise that they should be intubated and heavily sedated or even paralyzed if necessary just before the surgery. And if the size of the interatrial communication appears small, immediate surgery is not indicated. Balloon atrial septotomy or blade atrial septotomy may be performed to enlarge this communication. And in terms of corrective surgery, is necessary for all patients with this condition. So there's no palliative procedures. All procedures are intended to redirect the pulmonary venous blood to the left atrium instead of those 4 types where they usually drain. And then truncus arteriosus. This is a single arterial blood vessel which arises from the heart. The pulmonary arteries or its branches arise from the truncus arteriosus, and the truncus arteriosus just continues as the aorta. So there's usually a large VSD that's present with this condition. They usually have cyanosis and also some recurrent pulmonary infections. And then in terms of chest x-ray, they have cardiomegaly, and also ECG shows some biventricular hypertrophy. And management, it's usually diuretics and ditch. And in terms of repair, obviously we have to sort of separate these great vessels. So obviously your pulmonary artery should arise from the right ventricle, and your aorta should arise from your left ventricle. And then the VSD has to be corrected also with the corrective surgery. And the other type of lesions, I think these are the last 2. It's your Epstein anomaly. So there's usually a downward or displacement of the septal or posterior leaflet of the tricuspid valve into the right ventricular cavity, so that the portion of the right ventricle is incorporated into the right atrium. And there's also like functional hyperplasia of the right ventricle. You usually get tricuspid regurgitation, and also redundant tricuspid valve tissue can rarely obstruct the right ventricular outflow tract, which results in dilatation and hypertrophy of the right atrium. So an intercommunication, like an ASD with the right to left shunt, is present usually in all patients. And in severe cases, they may be cyanosis, even having congestive heart failure, which develops in the first few days of life. Subsequent improvement coincides with the reduction of the pulmonary venous resistance. And on ECG, you may find some right bundle branch block and right atrial hypertrophy. And I think this is the last one. Actually, second last one, yeah. So this is the hypoplastic left atrial syndrome. It usually includes a group of closely related anomalies characterized by hypoplasia of the left ventricle, atresia or critical stenosis of the aortic or mitral valves, and also hypoplasia of the ascending aorta and aortic arch. The left ventricle is usually small and non-functional or totally atriatic. So neonates with the hypoplastic left heart syndrome become critically ill within the first few hours to life, for the first few hours of life. And some of the characteristics that they present with it's usually tachycardia, dyspnea, pulmonary crackle, some weak pulses, and also these vasoconstrictive extremities. Patients may not have severe cyanosis, but they may have a grayish blue color of the skin with poor perfusion. The ECG always shows right ventricular hypertrophy. And then when you do a chest X-ray, it may show some pulmonary venous congestion or even pulmonary edema. And then echo obviously is diagnostic of this anomaly. And then the last lesion I want to talk about is the Eisenmenger syndrome. So with this, the pathophysiology, there's usually a systemic to pulmonary circulation connection. So there's usually a left to right shunting of the blood. So the increased pulmonary blood flow basically may cause some irreversible pulmonary vascular injury. And this irreversible pulmonary vascular injury may cause some resistance, which would basically cause an increased resistance, causing a right to left shunting of the blood. And your patients end up being hypoxic. And that's the last one. And then some of the references that I used, some information I got it from the Life in the Fast Lane. And then the textbook that I use is the Park's Pediatric Cardiology for practitioners.